Greetings, and thank you for joining us today. My name is Maribel Hernandez. I am a cardiologist at Lankano Heart Institute and the director of the Women's Heart Initiative. The Women's Heart Initiative program was developed to encourage women to learn the truth about heart disease and the risk it poses to your health. We want women to use this knowledge to make informed decisions with their healthcare providers in order to get the best and equal treatment and to live healthier lives. We're all here today to discuss an important heart health topic, menopause and heart disease. The idea that heart disease is a man's disease is a myth. The cold truth is that heart disease is the #1 killer of women in the United States. In fact, more women die of heart disease each year than all the women who died of all the cancers combined. Before menopause, women may develop heart disease, but at a lower risk than men. However, this protection fades after menopause, leaving women at risk for experiencing heart attack, heart failure, stroke, and death. Today, I have the pleasure to introduce two amazing physicians from Mainline Health System. Dr. Beverly Vaughn is an assistant clinical professor of OBGYN at the Sidney Kimmel School of Medicine. She's associate program director of the Lankano Medical Center OBGYN residency and medical director of the Lankano OBGYN Clinical Center. My colleague, Dr. Jenny Romanelli, is a cardiologist at Lankano Heart Institute, and she's the program director of the Cardiovascular Disease Fellowship. First, we'll start the program with Dr. Vaughn. Welcome.
Thank you so very much, Dr. Hernandez, for inviting me to present on this important topic. And I'm thrilled to be presenting it with Dr. Romanelli. She and I share patients, and it's such a wonderful and fortunate partnership. So to the audience, what Dr. Hernandez said is extremely important. There are a lot of myths out there about women and heart disease, and we need to take control of our health, and part of it's heart health. I think women don't think about a gynecologist worrying about your heart, but it actually is very central to what we do. So we're all gonna go through menopause. Either we've been through it, we're going through it, it'll be in our future. It's just the way it is. And we hope for this nice, easy, smooth road. You don't have your period anymore, you don't have hot flashes, everything is easy. Next slide. But that's not what we all get. Sometimes the road is windy. It can be windy for a long time or a short time. It's very unpredictable. And there's nothing in your personal history or in your health history or your family's health history that will give you a window into what your menopause is going to be like. Next slide. So I think it's really important to understand the terminology because it can be very confusing. So there's perimenopause, and that's as you're approaching menopause. And it's divided, we think of it in two phases. We think of it as early, and that's when your periods start to get a little wonky. You know, your period, you may have a couple of periods that are every 30 days, and then maybe you have one that's 40, and it's sort of back and forth. It's very annoying and it's unpredictable, but it's normal. Some women have hot flashes, some women don't. As you get further into menopause, your periods should get farther apart. You know, that's when they're 2 and 3 months apart, and then you get one's 1 month apart, and then you get one. It's still unpredictable. And many women, but again, not all, have hot flashes. Next slide. So then there's menopause, and this is really important. You're not menopausal until you've had 12 consecutive months without a period. So if you go 9 months without a period, you're still in perimenopause. If you go 11 months without a period and then get a period, unfortunately, that does happen to some women, then you have to start the count all over again. So it really is 12 consecutive months without a period, and then you're menopausal. And, you know, I've seen women who say, well, I'm menopausal, I'm postmenopausal. It's really all the same thing. Once you're done, and you're menopausal and postmenopausal. I use those words interchangeably. Next slide. So there is such a story about estrogen, and you know, it's been around for decades. And if you haven't seen it, there was a recent article in the New York Times Sunday magazine on February 6th, 5th, I mean, and if you can get your hands on it, do. It's a very well-written article, and it lays out the history, the good, the bad. It talks about the confusion that occurred around the study from 2002, which also was called the WHI, where very wise, skilled researchers looked at estrogen, and what they were looking for was to see if it protected against heart disease. And I'll get back to that in a minute, but it caused a whole tsunami of angst and change. So back in the 50s, it was thought by some doctors to be the fountain of youth. You'll stay young, your skin will be beautiful, you'll have a sex life, you won't have hot flashes, it'll be wonderful. And they gave women estrogen alone. And what they found was that these women who still had a uterus started to develop uterine cancer. And they didn't realize that you need to use progesterone with the estrogen. So then estrogen went from being, you know, the best thing since sliced bread to, oh, it's really horrible. Then as things moved forward, again, with evidence from some studies, with that it protects against heart disease. Now, here's what you have to understand about that. It can protect against heart disease in the right person who is of the right age. That study that I talked about earlier, the WHI, estrogen was given to women of an average age of 65. It didn't protect against heart disease in those women. And, you know, it's because it caused inflammatory change. So in a younger woman, yes, and I'll talk about that in a little bit, and I'll talk about why. In older women, no. So the adage that if you take estrogen, no matter how old you are, it'll protect against heart disease is not 100% true. So you have to remember that. It increases heart attack and stroke. Again, that comes from that WHI study. If you look at the women in that study who were older, who were already at risk for those things, it did increase it, not very much, but again, those were the wrong candidates for estrogen therapy. So in the end, it's beneficial in the right person. So you have to be the right woman with the right indications and without any contraindications to benefit from estrogen safely. Next slide. So why do women get hot flashes? What's the deal? What causes them? Next slide. So we all think it's about the hormones and decrease in estrogen. It's actually not. Women who have hot flashes and women who don't have the same level of estrogen when you test them. So it's all about your brain, and there's an area in your brain called the hypothalamus, and that's your center for temperature control. And there's an interplay between serotonin and estrogen and some other hormones, which I won't go into, which keep your body temperature stable. We call it the thermoneutral zone, where you're not too cold, you're not too hot, you're very comfortable. What happens in menopause in women who have hot flashes is that control is gone and women get hot more easily. So it really is about your brain and not solely about your hormones. Next slide. So let's think about what the indications for using hormone therapy are. Hot flashes in the right woman, absolutely. That's the primary thing that patients will complain about, and it is also the top indication for use of estrogen. Vaginal dryness and pain with sex, yes, but only using it vaginally. Using a pill or a patch that you might use for hot flashes really isn't going to address vaginal dryness. For bone health, women as they age, as you all know, are subject to bone loss and osteopenia and osteoporosis. If you are a person who's on estrogen, will it preserve your bones? Absolutely. But if you don't have hot flashes, it's not a reason to start estrogen, except in a very narrow case. So you can't ask for, I just want my bones to be healthy. That's not a reason to take estrogen. Prevention of heart disease? Absolutely not. For skin health, yes, you lose your collagen, you get some more wrinkles. Yes, none of that makes us happy. But taking estrogen is not an indication. Skin health is not an indication for taking estrogen. If you need to take estrogen, great. It's a side benefit. It's not a sole reason to take it. The libido question is really complicated because libido is multifactorial, and what has women have a good libido, a low libido, a topic that is too broad for this conversation. But estrogen alone, or estrogen at all, to be used for just decreased libido is not an indication. And actually, estrogen can lower your libido. So, if that's why you're going for it, you need to think about some other things and to think about why your libido might be not where you want it to be, because that's an in-depth, complicated conversation. Treatment for anxiety and depression. It is true that the estrogens can act in concert with antidepressants, but estrogen by itself is not an indication is not used just by itself to treat anxiety or depression. So I would not recommend seeking estrogen treatment for those conditions. Next. There are certain triggers that provoke hot flashes, and it's really important to know what they are. If you're a smoker, I've had smokers who have the worst hot flashes I've ever seen, and once they stop smoking, it gets better. Alcohol will trigger a hot flash. Stress will trigger a hot flash. Caffeine, spicy food, anything that's just hot when you drink it, like a hot cup of tea. I have question marks by sugar because it's not on the common list of things, but I've had enough patients tell me that they get hot flashes when they have too much sugar. So I have added that to the slide. So you don't necessarily need medication to help your hot flashes. You can change your behavior in some ways. And that's really the first step. And if that doesn't help, then you can move on to other things. Next slide. Okay, so there are women who can't use hormone therapy. And, timing is really everything. And we go back to that WHI study that showed increase in heart disease. Why? Because those women were farther out from menopause than 10 years. What happens when you're premenopausal, and as Dr. Hernandez mentioned, before you're menopausal, your risk for heart disease is there, but it's lower. And that's because the estrogen dilates your arteries, there's good blood flow, there's less development of plaque. As you get older and have decreased estrogen, and maybe you're hypertensive and other things, your arteries get stiffer, and you start to develop plaque within your arteries, especially within your coronary arteries. Estrogen administration at that time is what we call inflammatory. It breaks up the plaque, it causes pieces of it to fall off, and that's when you're more likely to get a heart attack. So that's why timing means a lot. So if you are 55 and are having significant symptoms and don't have any medical contraindication, then that's fine. If you are 62, totally different story. And there are other things to use. Obviously, if you have established heart disease, if you've had a stroke, if you've had a heart attack, you're not a candidate. If you've had a blood clot in your leg or your lung, you're not a candidate. If you have or had breast cancer, you're not a candidate. And there are certain types of lung cancer which are estrogen dependent, so estrogen is contraindicated. And there's some medical diseases like lupus where it may not be the best option for you. Next slide. Let me just see if this works. All right, so what about these medical conditions? There's so many women that have hypertension, diabetes, high cholesterol, obesity. If you have these things, it doesn't necessarily mean that you're not a good candidate, but you have to have your physician take a good medical history. Your hypertension has to be well controlled. Your diabetes has to be well controlled. Your cholesterol has to be well controlled. Why? Because if they're not, those things alone are going to increase your risk for heart disease. What I do when I have patients like this, and I'm on the fence about should I, shouldn't I actually will send my patients to get a coronary calcium score, which is a CAT scan of the heart, to look and see, are there a lot of calcium deposits already in the coronary arteries? Because if there are, I don't want to give that woman estrogen because, again, as I said before, it's inflammatory, it'll break the plaques, and then that woman will be more at risk for heart disease. And certainly if I have a patient who has a lot of coronary artery disease, I call up my cardiology buddies and say, please work with this person and work on getting things under better control. And I will then use other methods and medications that are not estrogen to try and control their hot flashes. So here is the intersection between cardiology and GYN. And this is why it's important for us to think about things more broadly and work together. Next slide. So, what's a person to do? There's some people that want treatment. There's some people that don't. Not everybody needs it. If you don't have really significant hot flashes, it really is a personal choice whether you want to use medication of any sort or not. Next slide. So there are a lot of options, and I'm not going to name things, but you can take estrogen by mouth. There are patches that you can use that you put on your thigh or on your abdomen. There are gels that you put on your arm. There are creams that you put on your arm. There's a mist. There is one vaginal estrogen. It's a ring, and I'm going to name it. It's called FemRing, and that you can use for hot flashes and vaginal dryness. There's another ring that you can only use for vaginal dryness. They're not interchangeable. If you're someone who has a uterus, meaning you haven't had a hysterectomy, you absolutely need progesterone. Remember way back when women were just given estrogen, they had an increase in uterine cancer. It's because they weren't given the progesterone. So that's an absolute must. You would have to take two things, the estrogen and the progesterone. Next slide. So what are the other options? As you can see, there's this whole list of things. And, this is a conversation that you need to have with your GYN. What things are good for you and will work and what things aren't. So the SSRIs, which are things like Lexapro and Effexor, are common SSRIs to use. And again, I want you to think back to that slide with the brain on it, and I talked about serotonin. If you block the serotonin uptake with an SSRI, it actually narrows that temperature zone that we talked about. So again, remember I said it's not only about the hormones, it's about your brain. These things work well. Use them in low dose, very few side effects. Not all of them work. For instance, Prozac and Wellbutrin don't work. So you really have to talk to your physician about the things that are going to be helpful. If you're someone who's already on an SSRI, that gets a little more tricky. You know, you may not want to change what you're on and may have to go for other things. Gabapentin was initially used for seizure control. Now it's often used for people with chronic pain. It was discovered incidentally that it works well for hot flashes. It's taken at night. You can titrate your dose up. Some people find that it's easy to take. Some people find that it makes them just really wiped out and tired. But it's an option. Clonidine is an antihypertensive. I will tell you, I personally don't use it that much. People have a hard time with it. They get constipated. Cognitive behavior therapy. That is newer on the scene, for, probably about 4 or 5 years. It actually does work well. They started using it in England for women who had breast cancer and couldn't use estrogen. You can look for things online, and it has to be cognitive behavior therapy that's geared towards hot flashes. There may be some practitioners in the area that use it, so you can check that out. Oxybutynin is a medication that is used for incontinence. Nobody knows why it works for hot flashes, but it does. It has some side effects like constipation and dry mouth, so I think it's probably pretty hard to take. I think I've only used it in one individual. Progesterone is my go-to because it works really well and it doesn't have the side effects, the negative side effects that estrogen may have on your heart. I give it to people orally, which is generally the way you take it. And you take it every day. You take it, I use a natural progesterone, and natural meaning it comes from plants, but it is pharmaceutically produced. It's FDA approved. But there are other forms of progesterone as well, and you can discuss that with your practitioner. But it works very well. And, I like that as an option. And a lot of patients like that as an option because they don't want to take an SSRI. So everybody talks about bioidenticals, and you can see my sign that says stop. This is all marketing. And you can't measure your hormones to figure out how much you need or how much you don't need. And the bioidentical hormones in pellets and in troches, things that you put in your mouth, they're not manufactured under any standard. They're not FDA approved. They may be different batch to batch. There's no robust study that says that A, that they work, and B, that they work any better than the pharmaceutically produced products. So I think it's really important to avoid them. That said, there are FDA approved plant-based hormones that you can use. So just because somebody writes you a prescription for estrogen or progesterone doesn't mean it's synthetic. There are a lot of things that are actually plant-based, so you can call them natural. They really are bioidentical, but they have standards that they have to adhere to, and they're safe and they've been studied. Next slide. So for vaginal dryness, there's a vaginal ring, which I talked about. There are creams, there are tablets or suppositories. There's an oral medication called Osphena, and I put it in parentheses because it's oral. There are DHEA vaginal suppositories, and these are not estrogen They are, you can call it a proestrogen. They encourage your vaginal cells to produce estrogen, and that's how you get a decrease in the vaginal dryness. Aspina is not estrogen either. But the important thing to remember is local, which is what I mentioned before. If you're taking something for hot flashes and you're taking it by mouth or using a patch, it's not really going to address your vaginal symptoms. So you might have to use something vaginally as well as what we call systemically to address both issues. Next slide. So this is always a question that needs to be discussed. When should women stop? First of all, you should use the lowest effective dose. You don't want to start out with a high dose. You want to start low, and if that works, great. If it doesn't, you can titrate up. The WHI study said, 65, no more, done, that's it. And that was because of what happened in their study. But so you don't want to start hormones then, and that was the problem with that. If a woman has significant symptoms that really affect her, this woman has no contraindications, you can discuss whether or not to continue. So there is no length of time anymore where you have to absolutely stop. There is no age where you have to absolutely stop. It's a discussion, and it's an ongoing discussion that you need to have with your gynecologist. And you can see in that last bullet, the American Congress of OBGYN and the North American Menopause Society, two groups from which we get our guidance, have said you can continue as long as it's safe and as long as you need it. If you don't need it, then there's no benefit to you. Next slide. So, yep, people can be hot, but it's the hot flashes. But, you can be hot in other ways too, as long as you're feeling healthy. Healthy. That's the important part. Next slide. So here are two resources for you. They're great. They're very patient friendly. There's a lot of information on all things menopause. I recommend it as resources to all of my patients. The information is accurate and it's updated, so you can always refer to them if you have questions. So thank you for your attention, and I am excited to hear what Dr. Romanelli has to say.
Thanks, Dr. Vaughn. I like doing these so much because it does show how we interact and work together. And I really think a lot of patients go to their OBGYN first. They've been seeing their gynecologist forever, and it's great. Gynecologists are now ordering calcium scores and sending them to us, which is wonderful. So I think it's a great interaction between the two of us. But I'm going to be talking out a little bit about the cardiovascular effects and what happens to us as we hit menopause. And as we all know, there's a lot more to menopause than just the hot flashes. As Carol says, as she's trying to cope for her hot flashes in the cartoon. But we go to the next slide, Heather. I'm bringing up this New York Times article that Dr. Hernandez sent to us about a month ago. And yes, it gave us a time to laugh and send emails back and forth. But it does bring up a couple of things. The New York Times article brought up a gold rush and use of telemedicine for hormone replacement therapy. And it's a good time to bring up that in today with telemedicine and everything being online, to making sure you get the right information, because you can pretty much read anything online that you want to read. So making sure that the resources are accurate. But the positives at looking at things like this, and in this article, they say menopause was historically saying you're not dead, but part dead. I watched a show on Netflix the other day, and it was a husband and wife, and he said, "Are you going through menopause yet?" And he said, "I don't know why it's not called menostop," and joking around about it, but you do wonder where the term came from. But the one thing it does bring up is the openness of the discussion today compared to years ago. When I used to see patients and I would ask them what their mother went through menopause, they would say, "I have no idea. My mom never talked about it." And today that has changed a lot. And you can see it as generations go through as a mother of 2 teenage girls, my girls are super open and my husband's gotten used to it. But I think that'll change as the years go on, and we'll know what I'm going through now. I'm 51 and being asked to do the menopause talk, but watching my kids go through puberty and their changes, it also brings up things, and being open really changes how we do things, and hopefully it's for the better because people feel more comfortable talking about it and seeking out help. If we can go to the next slide, Heather. So bringing up the change in estrogen as we age, which this is a little disheartening. Here we are at age 20, almost at our peak of estrogen. So as we age, by the time we hit 35, we are at our peak estrogen. And this precipitously drops as we age. By the time we're at 50, we're half. And then as we hit our 60s and 70s, you see the progressive drop in estrogen. Next slide. And what does this bring up? Well, it shows bringing up the drop in estrogen seems to correlate with the increase in cardiovascular disease. So for years, everyone always thought only men got heart disease, as now most people know women are definitely affected by heart disease. Does heart disease go up as we age? Yes, women do still get heart disease young, but here in the slide, in the age 40 to 59, in the premenopause and perimenopause age group, it's more men than women. By the time we reach 60, it's equal. So it really doesn't matter. It's the same amount of men and women being affected by cardiovascular disease. And then by the time we're 80, it's more women than men. And some of this may be because we live a long life too. So that's a positive, but we get more affected by cardiovascular disease as we age. Next slide. I keep wanting to click the slides. Bringing up the effect of cardiovascular disease on us as we age, this effect is much more significant as we age and hit menopause. Yes, women that are young and premenopausal do get heart disease. So I don't want to think we don't get heart disease young. We do. There's 1 in 7 women get heart disease premenopausal. By the time we're postmenopausal, it's 1 in 3. So 30% of us will have some form of cardiovascular disease at that point in life. Next slide. And then people always ask me, what is cardiovascular disease? Or do they have to write on a form they have cardiovascular disease? So bringing up what we're referring to by cardiovascular disease and the things that affect us as we age. One is angina or angina, which is a decrease in blood flow to the heart muscle. This is typically a form of chest pain or discomfort or shortness of breath. And it's typically as someone exercises or does things, there's less blood flow to the heart and a person gets uncomfortable. Arrhythmias become more of an issue as we age. And the most common one, and the one we always get concerned about, is atrial fibrillation. And unfortunately, atrial fibrillation increases our risk of stroke, and more women than men do have strokes from atrial fibrillation, unfortunately. Atherosclerosis, oh, can we slide back? Sorry, thanks. Atherosclerosis is the buildup of those inflammatory cells and cholesterol and plaque. This can occur in multiple areas. I say the cardiovascular system is pretty much like a tree, and to think of the aorta as the trunk with branches coming off of it. This atherosclerosis can occur in multiple areas to our brain, where we get strokes, our carotids, and up in our blood vessels to our brain, to our heart, even to our abdomen and GI system, and to our legs, which comes down to the PAD below. And that's the lack of blood flow to the legs, where people get almost angina to their legs. They get leg pain when they walk and do things, and sometimes even leg pain at rest. People and women always ask, well, am I going to have a heart attack? Or is my arrhythmia going to have a heart attack? Well, they're two separate things. A heart attack is an acute blockage in one of those coronary arteries where plaque and clot completely blocks off an artery, and there's no blood flow to the heart muscle, and the heart muscle starts to die. Heart failure always comes up, and I don't really love the term because we throw the term around a lot and refer to people as having heart failure when they're just because they're retaining fluid, but you can have heart failure as in the pump of the heart doesn't pump as well, whether it's because of arrhythmias or plaque or a virus or something that attacked the heart that can cause the heart to not pump. but some people get a form of heart failure where the heart function is normal and the heart is just stiff, and we have trouble keeping fluid off, and some people get shortness of breath, and this tends to affect more of our women than men, especially as we age, especially if we're diabetic, have hypertension and obesity. Hypertension becomes a big issue with our women, and women always come in and say, my blood pressure's been normal my whole life. I'm always like, well, it tends to go up as we age. So unfortunately, by the time we're 65% of women have hypertension. By the time we reach 75, it's 75% of us. So although most of us are normal when we're younger, it sneaks up as we age. So we have to be prepared for that. And stroke, once again, it's just already talked about, but this is lack of blood flow to the brain. And yes, women do suffer more strokes than men, especially if they have atrial fibrillation, which Dr. Hernandez is very familiar with. If you want to jump to the next slide. Now we can jump to the next slide. So what are causes of why do we have increase in cardiovascular disease after menopause? Well, we're not sure. Yes, it's probably has to do with the lack of estrogen, and what happens as our estrogen drops, we tend to gain weight, we tend to get central weight, but adding fuel to the fire doesn't help. Things like smoking can increase those risks, diabetes and hypertension, and family history. So we can only fight our genes so much, but we can try and prevent the other things. And if we have the genes, we want to be proactive. But if you're genetically predisposed to cardiovascular disease, you're at higher risk. I took this slide from somewhere else, so I don't like the HRT on there. I'm not here to be against HRT, but we don't use HRT to prevent cardiovascular disease. And if someone does have a cardiovascular disease, those are the people we prefer not to be on HRT. Next slide, Heather. Thank you. What happens when our estrogen drops? This is another thing that comes up in the office all the time, where someone says, my cholesterol has been great my whole life. Well, we hit our 50s and it starts to sneak up. The cholesterol changes in a profile that we don't want it to change. So the LDL, which is the low density lipoprotein, that's the lousy cholesterol. You want that to be low. That number tends to go up as you age. The HDL, I always call it the happy cholesterol to remember, you want that to be high. That tends to go down as we age. Also, unfortunately, our sugar starts to go up and we have decreased metabolism for glucose. We tend to gain abdominal fat and have more central fat, and we get fat around our organs as we age. Next slide. Just showing examples of, so we start to get fat deposits around several organs, our abdominal organs, and even around our heart, and even around our coronary arteries as we age and go through menopause. Next slide. So what are the other risk factors? So I always say you don't want to pour gasoline on a fire. So by smoking on top of things increases your cardiovascular risks. Unfortunately, diabetes, we don't always have some control over it, and some of this is genetics. But if someone is diabetic, we want their sugar to be controlled. Family history, once again, we can never change our genes, but what you can do is be proactive. If everyone in your family where there's a history of early cardiovascular disease, being proactive is super important. Other important things to bring up that not everybody realizes and think about, and Dr. Vaughn mentioned it also, is autoimmune disease. Diseases such as lupus, especially rheumatoid arthritis, these patients tend to be at higher risk for cardiovascular disease. I bring up radiation. It's not as much of an issue as it used to be in the past. The protection of the chest for cancers is much better than it was, but in someone that has a significant history of previous radiation to their chest, I like to know about it. I always ask them, they have breast cancer radiation, what side it was on, just to know how much chest radiation they've received and their increased risk for cardiovascular disease as they age, and we can be more proactive. I typically ask a pregnancy history, and someone came in the other day and said, well, why do you need to know that? And I said, well, I want to know what your risks are. So I always want to know if someone had gestational diabetes or preeclampsia, HELLP syndrome, hypertension with pregnancy. These increase a women's long-term cardiovascular risks. These women, as they age, and as I've known them for the years, I usually tell them I want to do a calcium score on them a little earlier than typical. Polycystic ovarian disease, endometriosis. Those with kidney disease, renal insufficiency tend to be at increased cardiovascular risk. Some chemotherapeutic medications can affect the heart. So if patients have had previous cancer with radiation and chemotherapy, we like to know. And then the timing of menopause. Next slide. Other concerns and things to be aware of is increase in anxiety and depression during the perimenopausal time may have an increased risk on someone's cardiovascular health. There are a few studies showing women with increased hot flashes and vasomotor symptoms may be at higher risk than the one that does not have them, but this is not totally clear. And those that don't sleep well and sleep disorders may increase one's cardiovascular risk. Next slide. So I show this slide that combines everything and how it all plays onto one's cardiovascular health. The traditional factors, we age, high blood pressure, smoking, lipids, diabetes, lack of exercise, sedentary diet, and family history. Want to take into account someone's pregnancy history, whether they have autoimmune disease, renal disease, previous radiation, timing of menopause, polycystic ovarian disease, and these all play into increased inflammation. It increases one's risk for cardiovascular disease. And we like to see all these patients and screen them to be proactive and preventative. Next slide. So what is the difference between men and women and what happens as we age? Well, 42% of women will die with 1 year of an MI compared to men. So unfortunately, we don't do as well as men do. Men for over years have been known to having more heart disease and watching our spouses and taking care of men. But unfortunately, we don't do as well. So we need to be proactive in taking care of ourselves. Yes, young women do also have heart attacks. I don't think that although it's less often, they do. You can see women with dissections and coronary disease even below the ages of 55, and they tend to not do as well. And 42% of women having a heart attack, unfortunately, do not have the typical symptoms. They don't tend to have the typical crushing chest pain. And we'll go over symptoms a little bit on the next slide. I think it's the next slide. Next slide, hopefully. Yes, so going over symptoms. And I know a lot of people have heard these symptoms, but they're really important to bring up. Women tend to present a little differently. They may just have fatigue or neck pain, jaw pain, shoulder pain, abdominal pain, some just shortness of breath. Pain in their arms. I have had women just have right arm pain, right hand pain. I had a woman once just with nausea and came to the emergency room and she was having a heart attack. Just a few sweating, dizziness, and sometimes just heartburn. And the unfortunate thing about all these symptoms, a lot of people have these and wouldn't think anything of them, and people come in all the time and they say, oh, so when do I know when to go to the emergency room? And I don't know of a better answer than if it's new and different for you and it's not going away, you can't be wrong by seeking help. The worst thing is to miss your heart attack. So if you come in and you're fine, that's wonderful. And if you come in and you caught your heart attack, you're going to do better. Next slide. What do we do? I mean, obviously, the more important thing would be prevention and working to not have a heart attack. So things we can do to maintain our cardiovascular health. And I go over this all the time in the office, and it's a lot of work. So it's maintaining our weight, bone health, balance. When it comes to exercise, I review with people, and I'm like, yeah, there's not enough time in a day. So we should be doing cardiovascular, so 75 minutes of vigorous or 150 minutes a week of moderate intensity exercise. It's hard to get that in, but you got to give yourself a couple hours. Everyone deserves a few hours a day for themselves. When you think about it, if you give yourself 45 minutes a day, you're going to get all this in. Strength training, I do talk to women as long as they don't have a dilated aorta or risks with low level weights, to do low level weight strength training to maintain their muscle mass. Balance is super important as we age. And as you age, you realize, you know, you can't lean over and tie your shoes and put your shoes and socks on as easily as you could when you were younger. You want to maintain that balance. You don't want to slip and fall or have broken bones or broken hip. You want to try to do balance exercises and core exercises also, and fit that into the week. Of course, not smoking, watching carbohydrates and glucose, and monitoring sugar, and if diabetic, keeping the A1C controlled, cholesterol management. And as I talk about it in the office all the time, and someone will say, well, my numbers have always been fine. Well, what we call fine for a 20-year-old for cholesterol is not fine for a 60 or 70-year-old. And I always say, well, our risks go up as we age. So that number might have been fine when you were younger, but not fine as we age. And that's why we get more aggressive on lipid management as people age. And if necessary, discussing medications for sugar and cholesterol if they become an issue. Being proactive with regards to one's risks and their genetic risks. Next slide. Oh, I thought I had another slide coming up. But I also, like Dr. Vaughn, for prevention, like doing calcium scores too. If I find plaque and we get aggressive and people come in all the time and they say, well, what do you do? I'm like, I can't suck out the plaque that we have, but we can be proactive. We know it's there and we're going to work to maintain it from getting worse and decreasing inflammation.
Thank you both, Dr. Romanelli and Dr. Vaughn, for this excellent presentation. If anybody in the audience have any questions about heart health, our virtual webinars, or any of our Women Heart Initiative events, you can contact the Women's Heart Initiative. You can go to the email, you can email mlhwomensheart@mlhs.org. Thank you.